Thank you again for joining us this evening. Again, this is the Gecko Forum for GI and Liver Fellows, and it's run under the auspices of the Gastroenterology Foundation, Gastroenterology and Hepatology Association of Sub-Saharan Africa, in conjunction with Project ECHO from the University of New Mexico in Albuquerque. And this program, of course, runs every second Monday evening at this particular time. It's my great delight to welcome Dr. Barbara Makumbi tonight. Barbara is far better looking than me, and she is going to be telling us about the consequences of what some of us like to do, and then some, of course, do too much. And that is alcohol-associated liver disease. So, Barbara, over to yourself. And remember that the chat box itself is open for any comments and questions. And we look forward to your presentation. Take it away.
Good evening, everyone. My name is Barbara Makumbi. Thank you for the introduction, Prof. I am from Charlotte Maxeke Academic Hospital at Wits from the University of Wits, and today I'll be presenting alcohol-related liver disease. As a means of introduction, I'm going to begin with an epidemiology of alcohol use. The World Health Organization attribute 3.3 million deaths every year to the use of alcohol. 6% of all deaths globally are due to alcohol, and 139 million disability-adjusted life years are attributed to alcohol. Globally, alcohol is the cause of 50% of all liver disease, and alcohol use disorder is more common in males and females. Geographically, there's a wide variation in the amount of alcohol used in different countries, depending on culture, etc. And alcohol is attributed to 200 diseases worldwide. So that being said, there's definitely a pertinent public health issue related to alcohol use. And looking at these headlines that I found online, related to Africa and South Africa as a whole, we do have a big problem. Just to go back to a bit of physiology, looking at alcohol metabolism, you basically have primarily in the liver metabolism of alcohol. However, the stomach also contributes to some of the metabolism. There are three major pathways, and the most important one being the alcohol dehydrogenase metabolism, which contributes to low concentration of alcohol. Then you have your cytochrome P450 with your CYP2E1 metabolism pathway. And this actually contributes to the metabolism of higher concentrations of alcohol. It's upregulated by exposure to ethanol, and therefore is important for chronic alcohol use metabolism, so faster metabolism of alcohol. The least important would be your catalase pathway, and all of these pathways result in acetaldehyde being produced. Acetaldehyde is a highly toxic compound, which is very active, and this is actually responsible for your systemic toxic effects of alcohol, including nausea, headaches, and flushing. To highlight a few definitions for a few things that have changed over the years, you have previous terms such as alcoholic, which has changed to alcohol use disorder. So I'd refer to alcohol use disorder as AUD. Alcoholic liver disease, alcohol-related liver disease is a new term. Alcoholic cirrhosis, cirrhosis due to alcohol-related liver disease. And the list goes on. So stigmatizing individuals by saying the word alcoholic has been seen as undermining patients' dignity and self-esteem. So therefore changing the terms. It's important to quantify alcohol and alcohol consumption, but this can get pretty complicated when you're seeing a patient. So most literature talks about grams of alcohol per day or week. So when we talk about grams of alcohol, we need to look at what a standard drink is. So there's different types of drinks. Different types of drinks have different percentages of alcohol. When we talk about pure alcohol, according to the ESL guidelines, 10 grams equals 1 standard drink of pure alcohol. The ASLD says 14 grams. And then you look at the volume that is being consumed. So looking at the picture on the right-hand side, it's illustrating the standard drinks in order of increasing ethanol content. So they look at regular beer and then go on to distilled spirits. Other definitions to highlight would be binge drinking, for example. So we look at patterns of alcohol consumption, continuous pattern of drinking versus binge drinking, which is defined as consumption of, in women, 4+ standard drinks, or in men, 5+ standard drinks within a 2-hour period. Harmful drinking and heavy episodic drinking also have their own definition. So as I've illustrated, patterns of drinking are important, and stopping and cessation of alcohol actually does change the natural history of liver disease. And basically, there's a meta-analysis that I saw and that was done in 2010, trying to delineate what a safe standard of drinking could be. And we generally recommend this to be 2 drinks for females and 3 drinks for males. And this is related to the 10 grams of alcohol as a definition. So the amount increased from this amount is an increased morbidity and mortality related to liver disease. So the term alcohol use disorder, which I've illustrated, actually has criteria for its diagnosis. And it's important that when we come into contact with patients who have a potential alcohol use disorder, we screen them, because early diagnosis of alcohol use disorder prevents the complications of alcoholic liver disease later. So guidelines say primary care level, at GP level, emergency room, or emergency department, and like patients we'd see with liver disease, we need to have thought of possible alcohol use disorder and screen these patients, which I'll highlight how to do in the next slide. So the criteria for alcohol use disorder is 11 criteria as shown in the DSM-5 criteria, and 2 criteria being positive means the person has alcohol use disorder. So it can be mild, moderate, or severe, and more criteria positive means increased severity. And this must take place in a 12-month period, all these yeses. So how do we screen these patients? Screening tools are used, and there are a number of screening tools that can be looked through. Some being questionnaires, which might be a bit subjective, depending on how honest a patient is. Maybe giving them a diary to keep track so it's more accurate. There's apps that are available to use as screening tools. But the audit questionnaire is the questionnaire that's most validated. It's been translated into many different languages, used in many different countries, and it consists of 10 questions. There's also the Audit C, which is a shorter version, which actually uses 3 questions and sees if somebody has risky drinking. And then there's 1 question, which can be used as a screening tool in cases of decreased time. How often do you have 5 drinks or more on one occasion? So alcohol use disorder is also associated with other disorders. You need to screen the patient for psychiatric disorders, and these may be independent or concurrent. Independent, they're known as a psych disorder, or concurrent based on their alcohol use, and this disorder will disappear, or this psychiatric condition will disappear once the alcohol use disorder is treated. Such as disorders such as anxiety and affective disorders can be related, as well as other substances such as smoking or polysubstance abuse should be looked out for. I'm not going to go into too much detail, but just to keep in mind that we need to be aware of the management of alcohol withdrawal syndrome. When we are stopping or advising people to abstain, we need to be aware of the signs and symptoms and how to treat alcohol withdrawal syndrome. There are severity scores available, and mainly 10 to 14 days of benzodiazepine, and obviously treating other related conditions too. Medical management of alcohol use disorder, the pharmacological treatment varies substantially, and a lot of the drugs haven't really been studied in liver disease. So this is a list of all the drugs that were in the guideline. for mainly EASL guideline. And the drug that is mainly studied in liver disease is baclofen. So it's the only drug that is actually recommended in alcohol use disorder. It was studied in a French guideline, but then they found that they found that the dose actually was detrimental if it exceeded the dose of 80 milligrams. So the recommended dose is less than 80 milligrams a day. Baclofen also basically helps in increasing abstinence and prevents relapses. So non-pharmacological treatment, is a mainstay of alcohol use disorder. Brief interventions, they've been shown to actually decrease substantially in mild alcohol use disorder, the amount that people do drink. You need to keep in mind, obviously, that MDT is important. Addiction specialists, your psychologists, psychiatrists, etc., need to come into play. And be non-judgmental, be motivational, advise about social support groups, and encourage the patient to decrease their use. So liver disease. The pathogenesis or pathophysiology of alcohol liver disease is quite extensive, but just to summarize, we have acetaldehyde, which is the main product that I already said is quite toxic, quite a toxic metabolite. It's an active metabolite. And this metabolite forms adducts with reactive residues on protein and small molecules. So when it forms these adducts, it makes a chemical modification and cellular toxicity ensues. When cellular toxicity ensues, the liver's host immunity is activated. And then there's other pathogenesis and pathophysiology where you have impaired glutathione transport, leading to decreased glutathione, which is an antioxidant in your liver. There's increased sensitization of your hepatocytes to TNF-alpha-mediated killing. You have lipid peroxidation, mitochondrial damage, and dysfunction that ensues. What's important too is your gut-liver axis. So alcohol does make your gut leaky. It increases permeability, resulting in bacterial translocation. So your PAMPs, which are your pathogen-associated molecular patterns, and in our textbook, it's this terrible picture, shows examples of your PAMPs at the top of the picture, which your lipopolysaccharides are one of the main ones. So the PAMPs basically go through your mucosa, through the gut wall, into your portal vein to the liver, basically. And in the liver, they are recognized by specific receptors, your toll-like receptors, and the innate immune system is then further activated, inducing more inflammation, more cell death, and later fibrosis. Injured cells then also release DAMPs. These are damage-associated molecular patterns. And these also increase your inflammatory reaction. This picture I thought was quite nice. It's a very nice article in the NEJM that illustrates the pathogenesis very, very well. So I'd advise colleagues to actually look this article up and have a look. The clinical presentation of alcohol liver disease varies depending on what stage the patient is at in terms of their liver disease. And this is just a list of all the different signs and symptoms that you'd find in a patient, or non-specific and specific signs and symptoms. Don't forget that alcohol is a systemic toxin. So it manifests in systemic disease. I wanted to highlight alcohol-related organ damage in the form of your heart, cardiomyopathy, pancreas, acute or chronic pancreatitis. Your kidneys, you can get IgA-induced nephropathy, and neurological complications, including your Wernicke's encephalopathy, your withdrawal syndrome, which I've mentioned, peripheral neuropathy, and cerebellar pathology. Risk factors for alcoholic liver disease. So we've talked about how many drinks or what the threshold or dose related response can be with the amount of alcohol consumed, patterns of consumption. Smoking actually is a risk factor on its own. Being a woman is a risk factor for alcohol liver disease, whereas alcohol use disorder is actually more prevalent in men. The genetics are very important, and having comorbidities in terms of metabolic syndrome are contributory. Other comorbidities in terms of other liver diseases, your NASH, your chronic viral hepatitis, hemochromatosis are important. What's protective is actually coffee consumption. Those are illustrated again here, but just to show the different phases of alcohol-related liver disease. So somebody that's actually drinking chronically or chronic alcohol abuse, 90% of patients with defined chronic alcohol abuse have steatosis, and they can be asymptomatic. It's theorized that this may be benign, but 20 to 40% of people will or can progress to fibrosis, and then 8 to 20% to cirrhosis. 3 to 10% can later have the complications of cirrhosis, including HCC. And remember, your alcoholic hepatitis is a different part of alcoholic liver disease as well, which I'll illustrate in later slides. So how do we diagnose alcohol-related liver disease? Diagnostic tests. So we've talked about screening of alcohol use disorder, which is important, and then screening for alcoholic liver disease itself and the diagnosis. They say that regular consumption of more than 20 grams a day for women and more than 30 grams a day for men in EASL. Clinical and biological abnormalities of your liver injury, abnormalities of liver injury. You need to screen those patients. And remember, like I've been saying, your alcohol use disorder patients may be asymptomatic, screen them. And somebody who has extrahepatic manifestations should be considered for screening. So we evaluate patients initially with our baseline liver function tests, etc. I thought it would be interesting to talk about the non-invasive alcohol liver disease versus NAFLD index, which is an index using your M4 parameters, including your gender, BMI, your MCV, and your AST-ALT ratio. So you use those parameters to differentiate between alcohol-related liver disease and NAFLD, and that index can help to differentiate between the two in a patient. Another way of evaluating alcohol use disorder, alcoholic liver disease, that's actually wrong, sorry, is to detect fibrosis. And if you suspect advanced fibrosis, they can actually present with a normal LFT. You need to exclude other causes of liver disease in these patients. And in patients that we have suspected fibrosis, it's important to evaluate for their liver function, like their actual function of their liver with their albumin, their INR and bilirubin, and look at platelets and white cells, and to have a look at their portal hypertension. It's important to look at hepatic imaging. Hepatic imaging to exclude obstructive jaundice, to exclude any other causes of liver disease and investigate further, but it also allows for quantification of steatosis. So you can actually detect steatosis on an abdominal ultrasound with a threshold of 20 to 30% steatotic liver, and MRI with 5 to 10%. So you have a patient, you think they have alcohol-related liver disease. Do we do a liver biopsy? What are the indications? So the main answer to that question is diagnostic uncertainty with this patient. So to establish definitive diagnosis, if you have diagnostic uncertainty, and if you have non-invasive tests that are inconclusive, you need to assess staging, maybe if you're doing a clinical trial, for example, or prognostication. You need to exclude other etiologies, and if there are additional injuries or other etiologies that may be coexisting with your alcoholic liver disease. And also, you need to make sure that you have a good reason to be doing a liver biopsy, because the risk versus benefit needs to be weighed. there are complications of liver biopsies. You may get bleeding, pneumothorax, etc., and patients can really deteriorate post-liver biopsy. So you have to have a clinical benefit and a therapeutic benefit when doing this invasive test. So just illustrating again the morphological spectrum of alcoholic liver disease. And now you've done your liver biopsy. What does the histo show? How do we diagnose alcoholic liver disease on a liver biopsy? There are a few parameters that are usually present, and these overlap with your fatty liver or your NAFLD liver, such as your macrovesicular steatosis. So this is usually present in a patient that has alcoholic liver disease. However, when you're cirrhotic, it actually can decrease substantially. It's usually macrovesicular, like I've said, but you can get a mixed type, which is actually an indication of progression of the disease. Then you can have hepatocellular injury with ballooning of your hepatocytes and potential necrosis as well. So what is ballooning? So ballooning of your hepatocyte is swelling, rounding, and pale staining cytoplasm. You can have loss of cytoplasmic staining of K8 and 18 constituents, which are intermediate filament cytoskeleton. And you can get Mallory-Denk bodies as well. So the picture illustrates your Mallory-Denk body, which is illustrated with the white arrow, and the black arrow illustrates a swollen ballooning hepatocyte. So looking at ASH histology further, so this is basically somebody who has steatohepatitis. Lobular inflammation would be present with your neutrophilic infiltrate. You can get mega mitochondria, and then if they're fibrotic, the fibrosis is usually in a chicken wire fibrosis, which is pericellular and sinusoidal fibrosis, as illustrated in the picture on your right side. In severe ASH, you can actually get ductular reactions, you can get cholestasis, sclerosing hyaline necrosis, alcoholic foamy degeneration, and fibro-obliterative changes to hepatic veins and your portal veins as well with acute inflammation. There is a score for histology showing severity and prognosticating alcoholic liver disease and ASH. This is your alcoholic hepatitis histological score, which would be good to look up. Other markers of fibrosis in alcoholic hepatitis, your serum markers can be used, and they're indirect and direct serum markers. So the indirect are indirect, and the direct are surrogate markers for your extracellular matrix and the turnover of the extracellular matrix. Your fibro test, your APRI, your FIB4 we've spoken about, and then you have enhanced liver fibrosis tests, and that's a surrogate for your extracellular matrix turnover. As you can see at the bottom of the screen, it just shows the cutoffs and basically the prevalence and the number, the positive predictive value, etc. So this article is available in my references. Okay. Another way of assessing fibrosis in these patients, your fibroscan. So fibroscans in patients with alcoholic hepatitis, so your patients with your steatohepatitis with inflammation that's present, are very difficult to interpret. The reason being is that fibrosis, which you're trying to assess, versus inflammation can muddy the waters, and you can't really, it may actually overestimate what you think is fibrosis in that liver. So if an ALT is more than 100, it's wise to interpret your fibrotic score with caution in a patient with alcoholic-related liver disease. Cutoffs are higher for alcoholic hepatitis / alcoholic liver disease than viral. And alcohol consumption, so if somebody is abstaining from alcohol versus if somebody is actively drinking, may also muddy the waters as well. I think FibroScan is more highly accurate in patients with NAFLD, according to studies, and it hasn't been extensively studied in alcoholic liver disease. There are tests to see what your patient has been consuming in terms of alcohol, or not what, but if they have, if they've been abstinent or not. You can look at your GGT, your AST, which is usually higher than your ALT and less than 300. And then your AST-ALT ratio, which should be more than 1.5 to 2, and your MCV. There's another indirect factor called your carbohydrate deficient transferrin. So it is a type of transferrin that it results from alcohol inhibiting glycosylation of your transferrin. It's reported as a percentage CDT per total transferrin, and this accounts to different total numbers of transferrin in patients, basically. It confirms heavy drinking, which they defined as more than 50 to 80 grams daily intake over 1 to 2 weeks. And unfortunately, it has a low sensitivity, 25 to 50%, and has high false positives. So it should be used with caution. They say that liver disease itself can actually make the test give you a false positive. And there's factors such as gender, smoking, and BMI that can make it inaccurate. However, post-transplant, it seems to be more accurate in those patients with a normal liver. Direct markers of alcohol consumption. So you have products of non-oxidative metabolism of ethanol. So these are basically able to be detected after a longer period of time post-consumption of alcohol, compared to like your blood or exhaled air levels. They're more specific than your direct, indirect tests. You have ethyl glucuronide, which you can see in urine, or you detect in urine or in scalp hair. So in urine, it can confirm abstinence, can be monitored regularly in addiction clinics or patients on the liver transplant waiting list, etc. And you can detect alcohol for up to 80 hours post-ingestion. It's not influenced by compensated or decompensated cirrhosis. And its sensitivity is 89% with a specificity of 99%. With hair, this also can determine short and long-term use. So 1 centimeter length positive represents 1 month. And this are different types of hair. Has somebody put product in their hair? Is their hair dye? It can only work in certain settings, but there is a good correlation with daily ethanol intake. Same article that I referred to previously shows the direct and indirect markers of alcohol consumption. This would be worth looking at because it shows confounding factors for each test. Looking at alcohol-associated hepatitis, certain criteria need to be reached in order to diagnose this. Onset of jaundice within previous 8 weeks, ongoing alcohol consumption, more than 40 grams in women and more than 60 in men, for 6 months with less than 60 days abstinence before the onset of jaundice. Total bilirubin, more than 50, AST, more than 50, AST-ALT ratio more than 1.5 to 2, and both AST and ALT must be less than 400. Rule out any other liver disease, such as your DILI, ischemic liver hepatitis, viral hepatitis, and with your imaging obstructive jaundice. So these patients actually can present with or without compensation, with ascites or hepatic encephalopathy, and they generally complicate with infections and ACLF, etc. They have a poor mortality, high mortality. This is a flow diagram from the NEJM, basically saying similar criteria. But they do say GGT more than 100, a low albumin, INR more than 1.5, and platelets less than 150 are also indicative in some cases. And they also say non-immune hemolytic anemia is also a factor that can come into play. They illustrate the role of transjugular liver biopsy, which I didn't mention. being safer because transjugular, these patients have coagulopathies. It would be advised to do a TEG before you do a liver biopsy in these patients to see where you can correct the coagulation status. So transjugular is safer because there's decreased rates of bleeding for patients that have a transjugular liver biopsy. And they suggest the transjugular liver biopsy with atypical presentations, as I've illustrated, where your ALT is more than 400, where you have uncertain alcohol assessment. It's not clear whether this person actually has alcohol use disorder, or confounders like we've talked about already. And when you have your liver biopsy, you have definite autoimmune hepatitis. So this is biopsy proven, it's definite. When you're going on clinical diagnosis, probable, clinically diagnosed without confounders, and possible, clinically diagnosed with potential confounders. And the possible generally need a biopsy. Evaluation of the severity of alcoholic hepatitis. We use our Maddrey discriminant function. So this score is a score that we use to determine the short-term mortality of a patient who has alcoholic hepatitis. If the cutoff is 32, if more than 32, then a patient has a 50 to 85% risk of mortality. If less than 32, less than 10% mortality in 1 month. So it can only determine 1 month prognosis. Usually, if more than the score is more than 32, we initiate corticosteroids, which I'll elaborate on in the next slide. We can also use our MELD score, and more than 20, we can also initiate treatment. This is helpful in predicting your 90-day mortality. Thereafter, our dynamic LILS model or LILS score is used. So the LILS score is used to determine early improvement secondary to steroid use. So you initiate the steroids on day 1, and at day 7, you look at the factors, including your bilirubin from day 1, and the change at day 7 or day 4 in some literature that people are doing it. It's been studied to be done earlier. So the reason to assess this is because steroids do have side effects. We don't want patients on steroids having GI bleeds, having sepsis when they're not responsive to treatment. So there's no need to expose them to this treatment. So if the LILS score is more than 0.45, the patient is non-responsive and you discontinue treatment. Treatment of alcoholic hepatitis. So just general measures, your abstinence, which we talked about, look out for the other organs, the systemic effects of alcohol, including Wernicke's encephalopathy. You need to replace your B vitamins, give them thiamine, treat withdrawal, etc. And your general measures that you treat your liver patient with. I thought it would be important to highlight nutrition. Most of these patients have protein energy malnutrition, they're sarcopenic, they're malnourished, so they need certain, they need to be referred to dietitian, but they need to have daily energy intake monitored very closely. 35 to 40 kilocal calorie per kg of body weight should be given, with daily protein of 1.2 to 1.5 grams per kg body weight to maintain calorie and protein intake. It was found that patients that had less than 21.5 kilocal per kg body weight intake a day had significant increase in their 1 and 6 month mortality and increased rates of infection. We want enteral feeds. So if a patient can't eat, NGT or MediFeed or any other enteral way of giving enteral feeds is advocated. In terms of IV or parenteral feeds or TPN, that's not really advocated, and that increases risks of sepsis in a patient that is very prone to infection, which is my next point. They get frequent and severe infections, and most patients actually die from infection, especially the cirrhotics. So DOPA which I'm going to illustrate soon, talk about soon, is had patients that had alcoholic hepatitis, and 24% of deaths from STOPA, the STOPA trial, were due to infection. This is because of dysbiosis and bacterial translocation as being one of the factors. Steroids were given as well, or steroids can enhance infection that's already there. And they basically cause a defect in lymphocyte signaling. So it's bacterial and fungal infections that we need to look out for. And it's prophylaxis with antibiotics is something that is debatable, and it is advocated in some literature. So when we talk about treatment, the mainstay of treatments are corticosteroids. The most extensively studied drug for alcoholic hepatitis is steroids. There are many, many trials over many, many years, but they're all inconsistent results, and heterogeneity does exist. So in terms of the STOPA trial, it's the largest randomized controlled trial in severe alcoholic hepatitis, and it looked at prednisone or pentoxifillin. So it was a large, multi-center, double-blind trial that was conducted in the UK between 2011 and 2014. They enrolled 1,103 patients, all clinically severe autoimmune hepatitis, actually, and they weren't biopsy proven, clinically determined. The study did not show statistically significant benefit of steroids at 28 days in patients receiving steroids versus placebo. However, in the post hoc analysis, the steroids were associated with improved 28-day survival, but not 90 days and not 1 year survival. And I've mentioned side effects, and usually we initiate prednisone 40 daily for 28 days and then taper over 3 weeks. Pentoxifillin, according to the STOPA, no longer recommended. N-acetylcysteine is an antioxidant. And we've spoken about oxidative stress. That is one of the pathophysiological means of alcoholic hepatitis. And this helps restore the glutathione stores. In a randomized controlled trial in France, they looked at the co-administration of steroids as well as N-acetylcysteine. And this actually reduced early complications such as infection and HRS versus steroids alone. So it is recommended to give N-acetylcysteine. They say in the same dose that you'd give a paracetamol overdose, or for 5 days, 10 grams a day, IV plus your prednisone. Your granulocyte colony stimulating factor has been looked at. This is a glycoprotein that stimulates bone marrow to produce neutrophils and stem cells. It results in liver regeneration, and giving it for 5 days subcut was actually shown to help some patients. I need to look at the studies further though, but there was negative results in decompensated patients. I think more studies are actually needed for this. I liked this diagram because it illustrated everything I've just said in one diagram. So I'd also wanted to highlight that they say assess for contraindications to treatment. That's actually from another article that I placed on this. So they say uncontrolled infections, not infections generally, but uncontrolled infections, may be a contraindication to steroids. AKI, so more than 2.5 milligrams per deciliter, uncontrolled upper GI bleed, other concomitant treatments, and multi-organ failure and shock. Going on to our cirrhotics. So you get regenerating nodules, abnormal sinusoidal blood flow, steatosis and lymphoproliferative infiltration is decreased. Your mammary DINK bodies can actually still be present for several months after abstinence. Or if the patient is cirrhotic, they can decrease in the number. And actually, they can also stick around with cholestasis. And then they talk about iron metabolism and iron accumulation as well in their histology. So in terms of the cirrhotic patients, we need to just look after them as you would the general cirrhotic guidelines, and you look at your portal hypertension, your Baveno guidelines, etc. Make sure you calculate their MELD and their Child-Pugh scores and act accordingly to those. I'm not going to go into too much detail there. However, I did want to mention some pertinent complications related to patients with alcoholic liver disease. In terms of mortality, and this is basically most cirrhotics, at 1 year with decompensation, with ascites, the mortality rate for 1 year becomes 49%. After variceal bleed, also 49%. And with hepatic encephalopathy, 64% mortality. Looking at sarcopenia, we've discussed that you get increased catabolism with insufficient calories. You need to look at their micronutrients and vitamins, and their BMI anthropometry is very important to monitor in conjunction with your dietitian. Malignancies, it's not just HCC. Patients that have alcohol use disorder and alcoholic liver disease are at risk of oropharyngeal cancers, gastric cancer, pancreatic cancer, kidney cancer, and the list probably goes on. When prescribing paracetamol to such patients, a patient that is drinking chronically at therapeutic doses, you need to be very cautious, and it varies from patient to patient. But it's something that you need to keep in mind with somebody who is taking in large amounts of alcohol with or without cirrhosis and with liver disease, as well as malnutrition. A therapeutic dose of paracetamol can be detrimental to this patient. Liver transplant. So it's liver transplant in somebody with alcohol use disorder previously, and now with alcohol-related liver disease, was seen previously as very controversial. Societal opinions were very negative towards this. But when we're working somebody up with alcoholic liver disease, ASH cirrhotic, somebody with a Child-Pugh score of C, a Child-Pugh C, or a MELD of more than 20, we need to start thinking about this. There are rigorous criteria, and a number of transplants have increased in certain countries for alcohol-related liver disease. So in the US, this has increased from 2004 to 2013 by more than 45%. These patients that were on the list had higher MELDs when they got transplanted. At Wits Donald Gordon, 10-year audit showed that alcohol-related cirrhosis accounted for 17.8% of liver transplants in 2004 to 2016. So how do we select our patients? We look at risk factors for drug relapse. It's very important to do a full psychosocial assessment in an MDT and assess their alcohol use disorder. Does this patient have any other associations with psychiatric disease? Has this been controlled? What's the are they using other substances? Do they have a family history of alcoholism? Thinking about genetics, etc. The entire MDT must be comfortable and happy with the fact that this patient is a good selection. 6 months sobriety. So this was the rule and is still the rule in some transplant units, that somebody must be sober for 6 months before they are able to qualify for a liver transplant. And this is very arbitrary. It's a difficult measure to make as a formal measure, because is it saying that this person must be sober for 6 months if they have alcohol use disorder, or generally? So does it have to be somebody that actually has alcoholic liver disease? The reasoning behind the 6 months was to say also that this patient could have a chance to recover from their liver injury, and maybe they don't even need to be listed. And identifying subsets of patients that, okay, they stayed sober for 6 months, they'll definitely stay sober post-liver transplant. It's very difficult to actually justify the 6 months sobriety, in my personal opinion. But I think this needs to be individualized. The lab tests that I mentioned are used for the waiting list. Early liver transplant is basically traditionally as well, the severe forms of alcoholic hepatitis that did not respond to alcohol, medical treatment, they're ineligible for transplant. But in 2011, there was a landmark trial by Franco-Belgian study, which is a paradigm, it's called a paradigm shift. They took 26 patients. They were carefully selected, severe alcoholic hepatitis patients, and they did early transplant for them. The cumulative 6-month survival was much higher than those that waited 6 months traditionally, 77 versus 23%. And then there's another trial called the Accelerate with Alcoholic Hepatitis Study, and also confirmed similar findings. And the follow-up for the initial 2011 trial with 2-year survival assessed showed similar findings between those that had early and standard transplant groups. However, the relapse rate was higher in the patients that had early versus advanced and waited, the patients with advanced alcoholic liver disease. So the early had 20 to 35% relapse, versus standard who had 10 to 25% relapse. So how do we decide? It's something that needs to really, really be debated. Not really standardized, but I believe individualized. If somebody, I think in the alcoholic hepatitis patients, if it's their first presentation with unknown liver disease previously, it really needs to be something that needs to be thought about, and patients need to be worked up. So there is the SALT score, which is a sustained alcohol use post-liver transplant score. This helps predict who will stay and in abstinence and has a low risk of relapse. Looking at more than 10 drinks per day at a time of initial hospitalization. Have they had multiple admissions to rehab? Have they had legal issues, previous illicit drug use? They look at cultural and socioeconomic factors, as well as genetics and family history. And that's the end of my talk. These are my references. Thank you for listening.
Barbara, thank you very much. That was a fantastic and very comprehensive overview of a very broad subject, and an issue that unfortunately is the very foundation of hepatology, and something that I think most of us, the length and breadth of the countryside, is probably seeing a bit more of over the last 2 to 3 years. This was certainly the experience that was reported in the US. COVID and the lockdowns contributed massively to increase amounts of alcohol use, and certainly there are a lot more kinds of patients presenting, as you've just sort of ended off the talk on, with acute or maybe acute or chronic alcohol-associated hepatitis. So this is not an uncommon, situation, and it's probably where most of us as medical students first encountered liver disease at the bedside. We encountered patients with cirrhosis related to alcohol, alcohol-associated liver disease. So it's very common. I mean, and just to give some perspective, before we just take some questions, I want to make sort of 1 or 2 comments. The one interesting sort of perspective on things that we often sort of talk about is, if you go back, I mean, we all go back to our teaching and fundamental training as medical students. And I'm sure the very first sort of clinical methods lesson you had about the abdomen, you were drilled into your head about looking for these features of chronic liver disease, the Dupitrons and the gynecomastia in males and testicular atrophy in males and spider nevi and pulmonerethema, et cetera, et cetera. And we can, any medical student can rattle that off. And the important thing is all those clinical signs that have sort of entered the pantheons of time, and that we all rattle off, those clinical signs fundamentally have their genesis in patients with alcohol-associated liver disease. That's where they were described by the physicians of old. And this was the kind of patient that they saw. So one important nuance is that whilst you may see here or there a feature in patients with causes of liver disease other than alcohol. When you've got this sort of palisading of features, when you've got spider nevi and Dupitrons and gynecomastia in the male and palmarothema and all these features, it really is a strong pointer that alcohol is either the primary or a strong component of the underlying chronic liver disease. And I think it's important just from a clinical perspective to understand that. I mean, we see many patients with chronic liver disease due to, say, chronic hepatitis B. One doesn't always see those features. It's relatively uncommon, unless, again, alcohol is a strong cofactor. So that's the one thing, just the sort of perspective I wanted to mention. The other issue is around the management of patients with alcohol-associated hepatitis. And as you've pointed out in the STOPPER study, this remains an area of quite limited therapeutic intervention. I mean, the results of the study, by any stretch of the imagination, were not fantastic. And when you start doing post-hoc analyses in data, then you are really starting to sort of look to find something. And unfortunately, you know, infection remains the bedrock or remains the Achilles heel of the entire intervention, because without steroids, patients are at risk of infection. With steroids, you just kind of ramp it up. So it's a major area of therapeutic intervention that is sort of wanting, and I think there is a huge amount of work. I see a comment from Professor Ramanati saying alcohol induces CYP2E1, which metabolizes paracetamol to the toxic NAPQI. And that's a very good point. It sort of crossed my mind as you were speaking about it. Again, I'm sure everyone knows that the CYP system that is involved in alcohol metabolism is CYP2E1, the same CYP that in fact metabolizes paracetamol. So it creates that clinical scenario where, for example, patients who chronically ingest alcohol are often at greater risk of a paracetamol injury because they've got so much induced CYP and tend to more rapidly produce the toxic intermediate, and at the same time also have reduced glutathione stores because of chronic alcohol use. So they're at greater risk of paracetamol toxicity and its effects, often at slightly lower doses. So it's something always to sort of think about as a risk factor. And then how different is methanol metabolized in the liver for those patients that are drinking unadulterated alcohol? I think it's almost been asked and answered already. Methanol is metabolized to formic acid, which is deadly, which is why ethanol is used as an antidote. Thank you, Dr. Ramanati. You're being most helpful in the chat box and answering questions. Sianda Matlasela, I see your hand is up. I don't know if you want to ask a question.
Hi, Prof. Great talk, Barbara. The question centers around the use of steroids in alcoholic hepatitis in those patients with a high discriminant score above 32. As I understand, most of that literature is based on the STOPPER trial, which essentially was just a negative trial. At 90 days, there was no difference in mortality. And giving steroids to these patients predisposed them to a higher risk of infections. So I'm wondering, how do you make the decision to give steroids? Do you give them to all patients if they have a high MADRI score, or is there a more nuanced approach that you take?
Barbara, do you want to go for it?
Sure. So yeah, like I illustrated in the talk, there are you do a full septic screen for the patient and make sure that there's no uncontrolled infection in the patient that you're trying to treat. If there's no other contraindications, such as the AKI we mentioned, and that there's no other possible etiologies for the liver disease, as illustrated in that NEJM flowchart that I showed. And if the patient does have infection, try to get the infection under control. And steroids aren't contraindicated in somebody that actually has controlled sepsis. So if the Madri score was over 32, then I would treat the patient to decrease their mortality.
Thanks, Barbara. Sia, it's sometimes useful to go back to history to understand where we find ourselves in sort of 2016 with the stopper study. You know, the Madri's score, in fact, was first, if memory serves me correctly, it was first proposed, and steroids were first proposed by Willis Madri, the designer of the actual score, in 1978. So that should make you depressed, because it's now 2023 and we haven't really made much way forward. The good news is guess what? Is that Dr. Madri was correct. He's, despite all those scoring systems that Barbara quite brilliantly pointed out to us, the little Madri's discriminant function has stood the test of time, which is good. I'm sure he'll be smiling about that. He's still alive, the last time I checked. Oh. So the discriminant function of 32, in fact, is very old, but it's wonderfully predictive, and it really has stood the test of time. And I must say, I think in my practice, and I see some of my colleagues on the line as well, I personally must admit that it's of the most difficult decisions I make at the bedside, and that is to use steroids in patients with whom I suspect to have alcohol-associated hepatitis. And I can tell you this much: the number of times I've actually used it are actually quite, significantly small in my career. And the reasons are many. It's because it's that balancing of first do no harm and balancing of harm versus risk. And so the patient, they're often, I mean, we all know these patients, they really are often quite sick. They really are. It's clearly why they're in hospital. And they're difficult clinically at the bedside because they often have a temperature, we've got a high white cell count. And so the question, first of all, is that driven by infection, or is that the alcoholic hepatitis? Because as Barbara quite correctly pointed out, alcoholic hepatitis starts in the gut. It's driven downstream from the gut, and all that bacterial translocation, all that gunk crossing a sick gut already driven already by alcohol's effect on the gut, driving this intense inflammation upstream. You see it down the microscope. You see those polymorphs. You see that intense inflammatory, intense inflammation. And so that's very polymorph predominant, and that's driving that white cell count. It's driving that temperature. So you can get on top of infection, absolutely, and you can then make that decision. But the contraindications are those ones with GI bleeding, uncontrolled infection. And we need to remind ourselves that all the therapies that have been looked at to date, including pentoxifillin, and I'm very sorry it had a negative outcome in the stopper study, because I personally always felt that I was a bit of a fan of pentoxifillin. The benefits of mortality, and Barbara, I don't know if you would have noticed that, the benefits of mortality, and you did point it out, in alcohol-associated hepatitis and decompensation and mortality. The mortality often is driven by twofold factors. One is the risk of infection, which of course you can make worse with steroids. But the other factor is the kidney injury. It's the renal mortality that drives it's the renal injury that drives mortality. And that's probably why pentoxifillin had that initial pointer towards, benefit, didn't carry through in stopper. So alcohol-associated hepatitis is a systemic illness, and the decision to make steroids should never be made lightly at the bedside. You should apply your mind to it, do the numbers, evaluate the patient, cover infection, and then make sure there are no those major contraindications. But if the time they get you, they're bleeding, they've got, creatinine that's careening off, and potential uncontrolled infection, then really there is no place for steroids whatsoever. You're actually just going to kill that patient, and they're going to die from overwhelming infection. Mashiko?
Thanks. I only want to ask the question if nobody else has a question. I don't want to hog the space on the fellows platform.
Well, we're almost at the hour, so I think, let me just have a look in the chat box quickly. It was thanks to Dr. Ramanati, who's doing a fantastic job there. What would I do without None? Unbelievable.
What would we do without
Get a medal at the end of the session, man. You're like
These are basic scientists.
absolutely fantastic. Thank you so much. Mashiko, go ahead.
Okay, so Barbara, excellent talk. Thank you so much. Budi, well, Mark, the question I have is classic acute alcoholic hepatitis. The only ones that I saw were in Caucasian patients in the UK. And I haven't done liver here in South Africa for a long, long time, but my sense was that it's only in Caucasian patients where you see this typical cytokine, just as described. And in our other patients, that's where it becomes fuzzy, and then whether you give steroids or not becomes a lot scary, as you've said. My question is that anecdotally, is my observation correct? And if so, do you think then there may be a genetic basis, or it's just a question of having confounders in the other patient groups, because they may have many other things going on, not just pure alcoholic hepatitis as described? Thank you.
Yeah, Mashiko, thanks for asking the most difficult but fantastic question at 7 o'clock at the hour, because I don't think it's an easy answer, because I think a lot of what you say is perhaps correct, but also things have changed. So I don't think you're seeing it purely in a particular demographic anymore. I do think things are changing, but I think the reasons why you say what you said and what you saw before, I think there is a strong nutritional and genetic component to that. And maybe you weren't seeing it in the local population, but I think things have changed, and you may see a different set of parameters, or you may see a different clinical scenario playing itself out. But I don't think it's as clear cut as what one thought it was 10 years ago, as you correctly saying. I think things have changed, but the reasons for it are actually multifactorial, and it comes down to nutrition. It undoubtedly comes down to polymorphisms, almost certainly, things like P and PLA and other factors as well, things we've yet to even understand and discover. And I just wanted to comment, sorry if I carry on here, because I see Neliswa made a fantastic comment. She said you have to be gutsy to start steroids in alcoholic hepatitis. Yeah, and I think that's and I think it's a very good point as well, just to reinforce kind of what I was saying. But Mashika, it's an interesting question. I don't think it's a simple answer at 7 o'clock at the hour, but I think things have changed, and I think things are changing. We're certainly seeing a very different demographic play itself out. But that original demographic is very much still in the play as well.
Thanks, Budi.
So, Dr. Makumbi, that was simply brilliant. Thank you very much. I thoroughly enjoyed listening to that. And I don't think we have any other questions in the chat box. It's way past the hour. You all need your rest. It's a school night. So I want to just thank GASA and Project ECHO for the platform. I think this is a fantastic platform. I think you guys do a superb job, and probably running your legs off every day at work and still getting this done. So it's fantastic. And I think the next session is in two weeks' time. It happens to be on a public holiday. In South Africa, that is, it's Workers' Day, but we're all workers, as you know, so it's just another day for us. We look forward to that, and that'll be chaired by Bilal Bobat. And the presenter there is Dr. Mokone Modise, looking at liver transplantation. So I don't think there's anything more to add, and just to thank everybody. And again, thank you most importantly to Barbara for a superb presentation this evening. Be well, everyone. Thank you, Karen.
Before everyone goes, I can just tell you in 2 weeks' time, it is a public holiday and there won't be a presentation. So the next one will be the 15th of May.
Oh, my apologies. My apologies. I'm thinking we're all going to not be workers and not take workers' day. So it's the 15th of May. My apologies. Yeah.
I'm very relieved about that. I felt bad that I'd missed that. Thanks, Karen.
But you must still come to work, Mashiko, on the 1st.
I'll be there, soldiering on. Thanks, guys.
Thank you, everyone. Bye-bye.
Thanks, everyone. Bye.
Thank you.